I'm going to introduce the moderator, Professor Seung-Ho Ho. I'm D.W. Park, and I'm introduce the world-renowned panelist, Dr. Paul Thun Rim Cham, and Dr. Vincent Ong Kwok, and Dr. Michael Lee, and Dr. Victor Rim, and Dr. Yong Bin Song, and Dr. Huai Chim Tan, and Dr. Chris Wong. Okay, Professor, yes.
Okay, I'm S.H. Ho from Keiming University, Korea. Let me introduce the first two speakers. The first speaker is Dr. S.J. Park from the Awesome Medical Center. He will talk about the non-left main bifurcation revascularization 2022 guideline and the concept change. Dr. Park, please.
Thank you. Right, so I want to talk about the non-main bifurcation. Right, main bifurcation is another issue, and so non-main bifurcation PCI is I would like to talk about the concept first. The clinical outcomes of a non-main bifurcation PCI clearly related with the main branch stenting status. And so, if side branch is small, so if you want to see that in the later, 80% of the main bifurcation is very small. Before or after the procedure, in any cases, do not touch side branches. That is the first concept. And all I want to talk in the next 10 minutes. Indication of a coronary artery revascularization for stable ischemic patients is just to, you know that, to improve symptoms, to improve survival. In symptom, wise, a symptom can be very much subjective from a doctor's point of view. Doctor want to do PCI, all right, patient had unstable ischemic chest pain. However, symptoms concern it should be ischemic symptoms. How to improve survival, based on the guidelines 2021, main disease and multivessel disease is low ejection fraction. Bypass surgery is class 1, 2A. Multivessel disease with a normal ejection fraction, even in the three vessel disease, PCI, bypass surgery, any revascularization would be 2B class, as in, a small weak benefit for that. Diabetic three vessel disease, bypass surgery 1A, they are a poor candidate for surgery. The PCI may be considered 2A and not, randomized study 2A. All right. Ischemia study is the most impactful study since courage study, since let me first remind you, ischemia study, included 5,000 patients, moderate or severe ischemia, and randomized with invasive strategy, PCR or surgery, and conservative strategies, and maybe 25% they include the PCI. In the later, however, initially they started with a conservative treatment. Primary outcome, composite of deaths from cardiovascular cause, myocardial infarction, hospitalization for unstable angina, heart failure, or resuscitate cardiac arrest here. So if you inclusion criteria, ischemia eligible criteria, you get this, nuclear perfusion and past studies, more than 10% myocardial ischemic, cases. That would be the, basics of ischemia study. And echocardiographic criteria, very severe, moderate to severe ischemia is by treadmill exercise test. Anatomy concern, 75% more than that, they included the multivessel disease. And so primary composite outcomes 3 years, actually no difference at all, primary and cardiovascular, all deaths, myocardial infarction, hospitalization, heart failure, resuscitation, cardiac arrest here. No deaths, all deaths, no difference, myocardial infarction, no difference. So last age meetings presented ischemia extended studies, more follow-up 5.7, median follow-up actually nearly identical, no difference at all in terms of all deaths. The main message doesn't change. What is the main message? Conclusion, no survival and ischemic event benefit of invasive strategy as compared with the conservative treatment for the patient with a moderate or severe ischemia. More than 75% of multivessel disease included ischemia study. So, main message I would say, optimal medical therapy is good enough for majority of a patient with stable coronary artery disease, and so we have to think about after ischemia study, unnecessary revascularization, especially PCI or even in the bypass surgery. And so they suggest individualized treatment if you compare with the coronary artery disease severity between the clinical outcomes concern. We would like to, we would define in terms of a high risk, group of patients, 3 vessel, more than 70%, and 2 vessel with proximal LAD disease. They stratified in terms of a high risk, intermediate risk, and low risk. And for the high risk patients, why not we do revascularization with a medical treatment on that, and remaining majority of patients and medical therapy alone is quite enough. So we're going to go back to the non-main bifurcation. It is what about the real size? So we're going to see that fractional myocardial mass in terms of a size-wise. If we look at this, LAD, proximal LAD, medial LAD, the total fractional myocardial mass in LAD case is almost 50%. It's quite a big one, even in the major vessels. However, look at this, circumflex is big, around 30%. However, diagonal, D1, D2, obtuse marginal branch, and the PDA branch, all side branch actually myocardial mass in terms of 10% less than that. It's not more than that one. So look at that. If we look at the frequency of fractional myocardial mass more than 10% here, this is the main branch, proxial LAD, medial LAD, circum, distal circum. Diagonal one branch, big diagonal, first diagonal, it would be 30%, would be sometime, 10% more fractional mass. OM1 is relatively frequent, and OM2 sometimes a big supply. Lateral myocardium supply PD is 10% of all. Only 20% side branch has more than 10% of fractional myocardial mass. The meaning is absolutely relatively small one. All right. LAD and circumflex, big, jeopardy area of fractional myocardial mass, and so we're gonna define 2 vessel disease, LAD circumflex, main bifurcation, something like that. However, the other non-main bifurcation, I would say, very difficult to present. However, 1.2 vessel disease, right? Exactly, 20% side branch is more than 10% of fractional myocardial mass, and so if you look at only one non-main bifurcation disease, think of it as a maximum, it would be 1.2 vessel disease. 20%. 80% is not a match with, around the 10% of fractional mass. In case of large side branch, right? It's clear. If you look at the only one non-main bifurcation, it would be 1.2 functionally vessel disease is medical disease. It's not surgical, not an interventional disease. If you look at the survival benefit here, ischemic versus at least more than 10% revascularization is better, such as main and multi-vessel disease here. However, in usual life, in the real world, PCI actually no survival benefit. The reason why the supply the myocardium, treated myocardium is too small. And after the ischemia study, only a minority of patients, stable PCI meet the ischemic criteria. And look at this, non-main small side branch have a small ischemic burden. So the meaning is no survival benefit of a non-main bifurcation PCI. So clear insight, medical therapy is good enough for majority of patients with a stable non-main bifurcation. That is conclusion, right? And so, all right, in details, how to treat non-main bifurcation, larger size branches, maybe 2 vessel disease, 1.2 vessel disease, you want to treat them. A small size branch, I would say, leave it alone, don't touch. So big vessel, all right, another new concept here, true bifurcation, medial class 1-on-1, upfront to two-stent would be good. Why upfront to two-stent would be good. A larger side branch is worse of treatment. We can avoid the risk of side branch closure during the procedures, immediately after the procedure, and clinical outcomes of two-stent are relatively good. So these are typical examples here, right? LAD and diagonal branch is very diffuse disease, maybe gets the more than 2.25 vessels, we're going to do two-stent, all right, for the non-limb main, even though sometimes you're going to do big vessel for the upfront to two-stent here. And another case, circumflex proper, almost near total occlusion, is long lesion, relatively big one, obtuse marginal, second one, you're going to make her, all right, upfront to two-stent with the crush technique like this. And so if you look at the data, not too much data about that. And one stent or two-stent crush, that is our data. And not too much difference in terms of a MACE. Recent published showing chance data. They use the DK crush mainly Kulu technique is better than the provisional stent, a single stent to come in terms of a target vessel, target lesion failure, MI is all the index would be good for the two-stent technique. So big vessel upfront to two-stent would be okay. Small side branch actually don't touch. I would say that one. So main vessel stent crossover, that is only treatment. Look at this, very typical examples here. Big side branch here, still there are some disease, TM3 floor. Immediately after main branch stenting, so getting more titers, compromised side branches. However, TM3 floor, patient had no symptom. We have to consider Libido. So another case is, look at the LED very diffuse disease here. So you want to do the stent for that. We lose the whole side branches, diagonal branch, D1, D2, and what's jailed? What do you think? If no symptoms, no survival benefit, why would you do further treatment? For even those cases, some compromised any small side branches, just leave it alone is our message. All right, the typical cases, LED crossover, big vessel, maybe more than 5 millimeter diameters, big side branches, jailing, and TM3 floor, all right, clear, no chest pain. What do you do then? Leave it alone. So why leave it alone? So even in the big side branch, more than 70, 80%, compromised here. If you look at that one, FFR would be negative, more than 70%. This is our data. So side branch, after the main stent crossover, jailing side branches, out of them, 72% negative FFR. Even in the, angiographic tight stenosis, 80%, 90%, these are not a big deal, right? And look at this second one, aggressive treatment, routine kissing balloon inflation and more stent for that, paradoxically increase target vessel failure. All right, this is data. Routine kissing balloon inflation actually cannot make any difference. Final kissing balloon immediately after and long-term follow-up, actually not too much different. This is our data. Routine kissing balloon inflation after the follow-up data. In a group of kissing balloon, proximal main vessel resource rate is clearly higher. Kissing balloon inflation, routinely. There is, we don't care about the, function, FFR. Distal main vessels has a little bit higher, higher rate. This is another data. High target vessel failure. If you do aggressive treatment side branches, higher, target vessel failure. Very interestingly, aggressive treatment paradoxically increased TVF in terms of side branches, so medical therapy is enough for small ischemic burden, right? This is almost, if a patient has chest pain, provisional balloon angioplasty with or without regulating balloon or regulating stent, okay, we can do that if a side branch is big. Main issue is if a patient has chest pain. So, all right, almost there. This is my basic concept for the non-main bifurcation. Clinical outcomes of non-main bifurcation PCI clearly related with the main vessel stenting status. And so if you want to treat ischemic, symptomatic, not biased operators, subjective evaluation, etc. Large side branch, upfront two-stent would be good, right? However, among the whole non-limb main bifurcation disease, only around 20%, less than that. Leave it alone. Any jail side branches, whatever size would be, if patient had no symptoms, medical therapy is quite enough. Right? So I would say non-limb main bifurcations, the concept, treat or not treat, which case is leave it alone, concept is more important than technique for the patient. Thank you.
Thank you, Dr. Box, your informative lectures. Let's move on to the second speaker, Dr. Jung-Min An from the Assam Medical Center. His title is Physiological Approach for Non-Left Main Bifurcation Disease. Dr. An, please.
Thank you, Chairman. Actually, essay already covered most of my talk. Briefly, I like to do my talk. For the non-left main disease, actually the decision is very simple. Simple crossover to stent side branch protection. There are lots of evolution of bifurcation therapy. Meta-analysis showed favoring the simple crossover stenting nowadays. So for this patient, the essay already show you these pictures. I'd like to insert the 2 wires after stenting. Yes, exactly same. So FFR was 0.84, so I'd like to leave it alone. Because the jail decided when FFR is more than 70%, the FFR is negative. It was also, we also observed the same finding with the Dr. Good's data. More than or almost 74% of jail decided range, the FFR is more than 0.80. So nowadays, we didn't do measure the jail decided range FFR because we already know that the FFR value maybe would be above the 0.80. So before we want to do more for side range, I'd like to recommend you to measure the FFR. But if you want to leave it alone, I don't like to recommend you to measure the side range FFR anymore. So why the side range FFR is just so high compared with our visual estimation? The FFR determined the 2 factors, the stenosis and myocardial burden. Stenosis itself, based on the angiography finding of side range osteum, is not accurate. Myocardial supplying myocardium is, as Jebak already mentioned, that the side branch supplying myocardium is not so big. Based on the myocardial mass, except the left main bifurcation, the non-left main bifurcation, the only 21% supplying the left main, 10% of left main. So this is simple calculation. Extent of ischemia, the side branch supplying the left more than 10% of left ventricle is only 21%. The FFR less than 0.0 in jail side branch is only 26%. So the chance this jail side branch may have clinically relevant is only 5.5%. Only 5 jail side branch out of 100 may have clinically the important jail side branch. In addition, our registry data show that the periprocedural myocardial infarction due to the jail side branch is not associated with the patient long-term outcomes. Then, when we have to treat the jail side branch because of patient symptom, how to predict the symptomatic jail side branch? This is Dr. Good's data. If vessel size is 2.5 big and side branch, diagonal branch number is less than 2, there is no side branch below that diagonal branch. That means only one diagonal branch in the LAD would be the symptomatically important side branch. So left diagonal branch would be the important symptomatically important side branch, but the right one less important, I think. Then my standpoint, my practical point, when we do initial two-stent technique, not due to the improved patient survival or a clinical endpoint, but due to not for better prognosis, but for no pain during the PCI. big side branch, how to rewire to avoid the patient pain during the PCI, I like to do upfront two-stent technique. For if the side branch vessel diameter is more than 2.5, like this, even though supplying myocardium is small. So based on our registry data, two-stent technique clinical outcome improved similarly to the simple crossover stenting nowadays. So sometimes diagonal branch disappeared after simple crossover stenting. Can we predict the disappear the diagonal branch after simple crossover stenting? Yes, we know the probability, but we cannot accurately predict the outcome of a JLG side branch. So I like to if there is a disappear the JLG side branch, I insert the wire to the JLG side branch. What is the next step? Based on the Dr. Good's data, if you do some kissing balloon, improve the FFR value up to follow-up, but the final kissing balloon itself may hazard to the main branch clinical outcome. So I'd like to recommend it just keep it open using the small balloon, not the big balloon, final kissing balloon dilatation. Just keep it open is my practice. Just to make a TIMI-3 flow, don't damage to the main vessel. Main vessel is way more important than side branch itself. So this is my final slide. Exactly same message with the SJ Park. Long-term clinical outcomes are determined by main vessel, not side branch. Some operators don't apply the high pressure for the main branch because of concerning of the side branch, but don't do that. Please apply the high pressure for main branch because main branch is more important than side branch itself. In addition, optimizing main vessel stenting is far more important than correcting angiographic appearance of side branch. Compared with the left main bifurcation, two-stent technique is less frequently performed in non-left main bifurcation PCI. I think because of smaller supplying myocardium of non-left main bifurcation. Thank you for your attention.
Okay, thank you, Professor An. And the remaining two topics is regarding the technical themed issue. And the third speaker is how to perform the optimal provisional stenting in non-left main bifurcation, and the Professor Ho Ram from the Hong Kong.
Thank you, Chairman, and good afternoon, everyone. This is my topic, how to perform the optimal provisional stenting. So, like all the bifurcation, concept is the most important. What's the key concepts? Provisional approach is for bifurcation that fit for provisional only. So be careful, don't choose those bifurcations that not fit for provisional and then you go for provisional. That's not good. The most important is how to choose correctly. And then you go for provisional. That is the most important and most challenging part. How to do is very easy. You can just gel something. Either you gel wire, gel balloon, gel microcatheter, or nowadays the most popular modified gel balloon technique, or another version is active transfer of part, just another name. And then if really the side branch close, then you go for kissing. And remember, don't do routine kissing, as the previous two speakers mentioned. And two-stent is the last option. So why will I say this as a key concept? Actually, selection of optimal case is very important. For example, like this case, there's a bifurcation. It's not uncommon to see. It's an MI case, choose provisional, and then stand across, and then close the diagonal, and then the patient arrest. So make sure the case is fit for provisional. And it's not just case. If you look at the data, look into the DK question 5, look at it carefully. So stent thrombosis in the provisional arm is very high. 6 stent thrombosis in provisional arm. And all the stent thrombosis case will fail the provisional approach, and then you switch to two-stent strategy. What is this meaning? That means if your provisional approach fail, you select incorrectly, you fail. And then even you successfully switch to two-stent surgery, you save the case, the outcome of the two-stent surgery is not good. You can see the stent thrombosis rate is 6 to 8 times higher than upfront two-stent surgery. So may not upfront two-stent surgery may not be better than provisional, but upfront two-stent surgery is better than fail the provisional approach and then switching to two-stent. So to perform optimal provisional stent, select bifurcation lesion optimal for provisional. That's most important. So we should focus on how to assess the risk of side branch closure and significance of the side branch. As Dr. S.H. Park mentioned, small side branch, you won't care. For risk of side branch closure, the most common mechanism is Park shift plus Carvana shift. It accounts for 80% of side branch closure. So the bifurcation angle and the part burden are the most important, particularly the part burden over the main branch, the proximal part of the main branch, and also the part burden over the side branch. Carvana length and dissection fat. So the person of cord and calcium is most unpredictable. So and if you want to follow study, definition 2 study give you a good suggestion on the criteria for predicting the side branch closure. But I think experience and gut feeling are very important. IFAS and OCT definitely can help. Like this case, it seems the bifurcation is okay, provisional, but if you use IFAS to see, actually the side branch ostium is full of disease, very tight, and the main branch part burden is very heavy. So if you stand across, the side branch will close. We go for two-stent in this case. And significance of the side branch, size and length is important, and also need to consider side branch distribution. For example, like this case, the diagonal is very big, and below that there's no side branch. That means this diagonal is very significant. Also, the significance of the side branch also depends on the patient's factor, for example, LV function, viability, and cholesterol issue. So the thinking logic should be like this, depends on the significance of the side branch, and then your threshold for provisional surgery will change. For example, a 2 mm short side branch in non-dominant left shirt and a good LV function. So despite the risk of side branch closure is very, very high, but your threshold for two-stent or the threshold to touch it is very, very high too. So no matter what happens, you won't touch. On the other hand, if there's a 2 mm long side branch in a very poor LV function patient and the side branch is supplying a CTO, so despite the closure of the side branch may be low, but if you touch your threshold for two-stent, it will be also low. So it's a spectrum of thinking. So how to do? This is simple. You can just gel something. I will show in the video. So this is a STEMI case, primary PCI. There's a big diagonal. Of course, you won't go for two-stent surgery, but you don't want to close this diagonal. So you don't want to repeat the story or maintain the flow, and then rewire the side branch. There are two terms, more or less said they are the same. And then you put the stent in the AD. At this time, we choose a 1.5 dB and put it on the side branch, and then it inflate together. That is the modified gel balloon. Actually, it's very controversial. There are many different approaches. Some of them will advocate the protrusion of the side branch balloon, minimal protrusion, but some will advocate more overlap, and some advocate usual balloon, some advocate DEB. But most of people will agree that we should just use small balloon, and then it's okay. That was the modified gel balloon technique. For other gel wire, gel balloon, gel microcatheter, no need to illustrate, it's very easy. If side branch close, most of the time, just closing. The most important thing is don't do routine kissing. Just do it when the side branch really close. So like this case, we wire and then we stand. We give the protect wire, we stand, we use gel balloon technique to this septal, but the septal still closed. So we have to rewire it. And then put a small balloon and then kissing and open up it. And that is the way of provisional strategy once your side branch was closed. Another is when in an extreme situation you want to do two-stent, but most of the time just kissing is enough. For example, this one is D1 closed. So what should we do? The first step must be eye first to make sure the stand position is good. And don't hesitate to do high pressure after the IFAS. And make sure, especially the proximal part, the stand position is good, and do the POC, and then review the old angiogram. So that you know the origin of the side branch, and then you rewire it. And most of the time you will open it with a small balloon and then use IFAS to confirm its true lumen. And the IFAS also help you to determine whether this side branch need a stent or just kissing is okay. For example, this case, we think that it's quite calcified, recoil will be very severe, so we put a stent. Most of the time in this case, we will use tap. And then the fold okay, and that's okay. So that is my thinking on provisional approach, how to perform it. The most important is select a good case that is fit for provisional. Make sure that if the side branch closed, the patient won't die. Selection is very important. And assess the side branch closure risk and assess the significance of the side branch. And think as a spectrum. And how to perform, that is very simple. I demonstrated a modified gel balloon technique. And if side branch closed, only if side branch closed, then go for kissing or two-stent. 90% kissing is okay. In the very, very last saw, then you will choose two-stent. And that is my presentation. Thank you very much. And it's my great honor to join the complex PCI again. Thank you.
Okay, thank you, Dr. Horam. And the last speaker, I'm going to introduce how to perform the optimal two-stenting in non-left main bifurcation, and Dr. Do Yoon Kang from Asa Medical Center.
Yeah, thank you. I will talk about how to perform the optimal two-stenting in non-left main bifurcation. All three presenters thought that do not do the two-stent, but I also agree. But there is some situation that we have to do two-stent also for the non-left main bifurcation. And I will talk how I'm doing and how we are doing in Asa Medical Center to optimize the two-stent technique. There is a big difference between left main and non-left main bifurcation as presented. And in our study, one-stent and two-stent technique in non-left main bifurcation, the outcome was comparable between one-stent and two-stent. In Europe, single-stent approach was associated with lower long-term mortality in the patient-level pooled analysis of the Nordic bifurcation study and British bifurcation coronary study. Therefore, the European guideline recommends a single-stent strategy with crossover technique as 1A. And the important thing is to never compromise the main vessel and to optimize side branch patency. And in the guideline, there is some exception when upfront side branch stenting may be preferable. This is the same sentence. The large side branch diameter equal or more than 2.75 mm with a long ostial lesion and anticipated difficulty in assessing side branch after stenting main vessel. That means that in case of the high risk of acute side branch occlusion in a sufficiently large branch, and then upfront two-stent would be needed. So when do we need two-stent in non-left main bifurcation? Upfront stent for large side branch with high occlusion risk. And some urgent situation during PCI with a large side branch dissection, with a persistent intraprocedural angina, and electrocardiographic changes, and sometimes with a low TIMI flow gradient. And which technique would be the best? Crush, Culo, T, tap? I think that the stenting techniques do not matter. Achieving the optimal result would be important regardless of techniques. And angiography only can discriminate optimal versus suboptimal result in angio. And intracoronary imaging based optimization is essential for complex two-stent technique. And this is the routine practice in AMC. Tomorrow you will be able to see many cases in real-time practice. We have some data. Then in the two-stent technique, the side branch ostium is the Achilles heel of the two-stent technique. The most, the record region is the side branch ostium. So optimizing side branch ostium is the key for successful two-stent PCI. And bigger stent area was associated with a better clinical outcome in two-stent PCI. And for that, intravascular imaging was associated with a long-term clinical benefit. It enabled to gain bigger stent area with better safety, with detecting acute complication and selecting optimal stent and balloon size. So this is our routine. Usually we are now using radial approach, and for the two-stent technique using 7 French and mandatory intracoronary imaging, antiplatelet agent, and usually the patient has planned the same day discharge. Now let's go along with the case. 73-year-old male patient and stable angina with a diabetes and hypertension. And the proximal LAD has a functionally significant disease, and there was a large, just one diagonal branch, D1, with a diseased vessel. So the RCA was deferred with the FFR basis, and we decided to perform the LAD stenting to treat the patient angina. And because the diagonal branch was large enough and severely diseased, and the flow was TIMI flow 2, so we decided to treat with the upfront two-stent technique. And always aggressive pre-lesion modification in this kind of the calcified lesion is important. We used the NC balloons, main vessel and side branch vessel with a 2.75 NC, and then perform side branch stenting with high pressure balloon at the main vessel. And we now prefer the minimal protrusion with the mini crush, and we need the multiple projection not to miss the ostium of the diagonal branch. This is areocranial view, but you need areocranial also for the diagonal branch the ostial visualization. This case, we perform 2.75 stenting with the crush balloon at the main branch with a 3.5 NC balloon. And then the next step is not just crushing. The next step is aggressive side branch proximal optimization before crushing. The opening side branch ostium with the NC balloon as wide as possible. In this case, we did the 2.75 NC up to 24 ATM. It enables larger side branch space for wiring and easy rewiring and balloon introduction. And it minimizes the risk of the abluminal wiring, also minimizes the risk of the stent gap. This is the visualization of this concept. The proximal side optimization enables safe crushing technique. And then perform the balloon crush with a high pressure. You can see the crushed stent strut in the stent boost or clear stent function in the recent angiographic machine. And then perform the main branch stenting. And then next step is to optimize the main branch stent with the NC balloons. We implanted 3.25 and then performed 3.5 NC balloon up to 26 ATM. Very high pressure. We could apply this high pressure with a bigger balloon because we checked IVUS or OCT in this case, and we know the vessel size and where is the normal vessel, and we could select bigger balloon safely. And then if you did this kind of steps, rewiring is usually easy. It was the usually used BMW wire before the first wiring, and the rewiring would be very easy in this kind of step. And this is balloon passing with a used 2.75 NC balloon. Balloon recross was also easy, and usually I use the balloon anchoring to cross the side branch ostium. And then sequential high pressure balloon inflation is performed to obtain sufficient stent cross-sectional area. The diagonal branch and LAD, sequential high pressure, make sufficient the stent expansion. And then roll of the final kissing balloon is just to put the carina in the right place. We do not need high pressure. And in this case, I did the 8 ATM. And then final step is the imaging surveillance and to check whether further optimization is needed. This is OCT case, and you could see that the side branch ostium is widely opened and without gap or stent strut, the good optimization. And this is the usually used imaging optimization criteria. The quantitative criteria is to achieve larger post-stenting minimal stent area. There was no universal cutoff value because of the various vessel size in non-left main bifurcation. And qualitative criteria would be a complete scaffolding and coverage of the side branch ostium, and good stent strut opposition to main vessel wall, and little or no stent strut just above or near the side branch ostium to close or interfere the flow of the main branch. And this is the final angiography after checking the imaging surveillance. And let me summarize my talk about the two-stent technique in non-left main bifurcation. First, avoid two-stent in most non-left main bifurcation cases as possible. But sometimes we need, and then intracoronary imaging is the key for the successful two-stent technique. And achieve optimal imaging criteria, larger minimal stent area, good stent opposition, minimal stent strut near side branch ostium should be achieved. Final imaging surveillance and correcting suboptimal result guarantee the favorable long-term clinical outcomes. Thank you for your attention.
Okay, thank you. We have a 15-minute discussion time, and any comment or any question to the presenter?
Maybe I can start. First of all, I would like to say that it would be good for everybody to just at least look at the European Bifurcation Club 16 consensus statement, because there's actually a lot of mentioning about what is the common nomenclatures that we should be using when we talk about bifurcation PCI. And also people have put in a lot of effort in describing what are the actual techniques involved, whether it's provisional stent approach. And this is my first comment. The second thing is that while I agree that the stepwise layered provisional stent approach should be the dominant approach in patients with non-left main bifurcation, it does not mean that we don't do anything about the side branch. While I will avoid two-stent strategy as much as possible in this non-left main bifurcation, I think I do less than 5% of two-stent strategy in non-left main bifurcation. It also does not mean that we ignore the side branch and allow it to close off, and so we should always take precaution to try to at least maintain the patency, whether it's by geode balloon technique or whether it's by just leaving a side branch wire across and so forth. So the approach is not just one of just lying flat and do nothing. But I just want to ask Dr. Kang, I know that two-stent strategy is feasible in north-left main bifurcation. The only problem nowadays is that we don't have a data to tell us that the two-stent strategy performs as well as a one-stent provisional stent approach in patients with non-left main bifurcation. In fact, if you look at the meta-analysis by Ford et al. in Journal of American Heart Association 2018, actually one-stent approach is associated with reduction in all-cause mortality compared to a two-stent. And just like also the earlier study you quoted as well. So there's actually mortality benefit in one stent strategy compared to a two-stent strategy. So how can we justify a two-stent approach if the patient has got stable disease, non-ischemic symptoms? How can we just based on the anatomy alone justify a two-stent strategy? In fact, the only evidence that I can gather from a two-stent strategy in North Left Main is the DK Crush 2 and the Definition 2. But Definition 2 is for very complex bifurcation lesion. DK Crush 2, no difference in major adverse cardiac event, only target lesion revascularization. But I'm not even sure if it's ischemia driven. So what is the evidence for us to even consider a two-stent strategy for non-left main?
As it's very complex situations, and that's why I concluded that we do not need two-stent technique for most of the non-left main bifurcation, because data does not support the routine use of the non-left main bifurcation two-stent technique. And also, as you mentioned, the meta-analysis and manual registry data do not support the routine use of the two-stent technique in non-left main bifurcation. So the use of the two-stent technique in non-left main bifurcation would be justified only for a small subset with as I mentioned, the big side branch that can make symptom, because the PCI for the stable angina is now for the symptom control, not survival benefit, no survival benefit, no additional benefit for the heart failure patient, just to treat symptom in stable angina patient. So if the branch is large, or in jailed patient, if the patient is suffered from the chest pain even during the patient is lying on the table, and then we need to treat that lesion. And if the lesion is small, and then if it can be treated with the small balloons, and then it will be a best option. But if the branch is large enough, and if it is compromised, it is likely to compromise in the angiography or intravascular imaging surveillance. And then performing two-stent technique, if the operator is feasible and familiar with that technique, that would not be harmful for the patient, I believe. But we need more data, and I think that in Definition 2 trial, they enrolled the very severely diseased the side branch, and the very technical, very experienced operators did the procedure, and that would be the cause of the trial that showed other result.
Okay, so Dr. Gang, you just shows your technique for the two-stent techniques. So you use the non-compliant balloon in the opening of the big side branch area before the crushing, the side branch crushing. So do you think that is there a difference the DK crush and your crushing technique using the high pressure balloon for the side branch before the crush technique?
Yeah, I think in our center we are thinking that would be non-inferior or more simpler than DK crush, because DK crush technique is a little bit too complex. So we tried some time, but we could not follow every steps of the DK crush. There was 10 steps in the blackboard, and we could not follow everything. But with introduction of these steps, the crush stenting was more simplified, and we could achieve the good angiographic and imaging outcomes with a very short procedure time. So if we to prove the superiority or non-inferiority of this technique to DK crush, we need a randomized trial. But we need more data. We are gathering the data with this introduction of this data. I will show you next year.
Since you're still up there, I'll just ask you to comment. Since basically seems the consensus is to keep bifurcation for non-left main as simple as possible without using two stents, since the ischemic burden is not very large. What is your experience of using drug-eluting balloon instead of a stent for the side branch. Since most Asians, I think the side branch are 2.5 or less, and if the results are good, may not be perfect, and the flow is good, would that be as good as putting a stent there? I mean, that gives the option that we don't have to use double antiplatelet for so long. What is your experience in real life of using that? Do you use it routinely
Oh, you mean that using the
side
balloon
branch.
for the side branch?
for the
And
drug-eluting balloon?
yes, just to keep it open, keep an open strategy for the non very large side branch, it works very well in my experience. And if the flow is maintained and the patient goes well without symptoms, and the survivor there's no difference, and then there will be a simpler and better way for the patient, and operators.
Okay, we have the remote panel and the Dr. Vincent on. And do you have any question or comment?
I think, hi panels, good to see you. Sorry for not being able to join you in person. I think, well, we all know that we've been doing a lot of bifurcation lesions. I think the more we do, we learn that the less we should intervene. So less is more. And it all depends on the anatomy and the angulation and the size of the side branch. And to me, I think the osteo side branch plaque burden also, determine whether we should go for a two-stent or single-stent technique. As the previous panel comment that if the osteo side branch burden is not severe, like subtotal occlusion, then probably we can just use a drug-coated balloon for the side branch and stent the main branch, tend to reduce the amount of stent overlap. The less metal, I think, the better the long-term outcome. But sometimes we are forced to do so. If you've got we came across patients with a huge diagonal and LAD coming in with a ST elevation MI, and the occlusion was sitting right at the bifurcation. So we have to stent the side branch. Otherwise, we have end up with a ping pong plaque or clot shift here and there between the main and the side branch. And debulking, if is a true 1-1-1 bifurcation, is also one of the strategy that we should consider.
Okay, thank you.
Can I make a comment as well? Calcium or calcification at the side branch ostium is also a very difficult situation, because if you just stent the main branch or main stem, the main artery, a lot of the time that the side branch calcium will occlude and very difficult to recross. So I think if you see calcium from IRIS or OCT, you might need to actually design the two-stent technique in a very early, rather than wait for a provisional situation, because otherwise you get yourself into a very, very difficult situation.
Okay, I have the question on Professor Song, and you have managed the many big data is COVID 1, 2, 3, and I think the theory is very simple. Non-left main bifurcation region and the jeopardized myocardium is not big, so provisional stenting, just the stent cross over is would be okay. But however, there is a theory point, but in practical point, sometimes we do upfront two-stent technique, even in patient with a non-left main bifurcation region. And on the basis of some cumulative data, COVID 1 to 3, or any evidence, and do you provide, and which patient subset would be good or would be better with the upfront two-stent technique in patient non-left main bifurcation region?
Yeah, actually, it's a very good and important question. So, yeah, actually, Dr. S.J. Bach already mentioned that defining the clinical relevance of side branch is extremely important, and I think it's a first step. So, especially in non-left main bifurcation lesions, so big side branch, and actually the most important prognostic factor is the lesion length. Side branch lesion length is a very important predictor of future event. So if a patient had the large ischemic burden and have a long side branch lesion length, yeah, in that case should be considered two-stent technique in left main bifurcation lesion.
Okay. In terms of old data, so from the large registry, something like that. Anyway, there is a concept is totally different one. I think so, right? The meaning is if you do any non-domain bifurcation PCI, think about that one. No more any invasive follow. Just post PCI study, just 1 year's clinical follow-up, something like that. 2 years clinical follow-up, any symptoms, any TLR, something like that. Do you expect any difference? Even in the two-stent, optional stent, drug-eluting balloon, something like that. The meaning is totally small myocardium. So whatever you do in the immediate for the procedures, we do a lot of medication in the good post PCI follow-up. 1 year is just no invasive, non-invasive, any ischemic test. We don't need that. 1 year follow-up, 2 year follow-up, we cannot find any difference. The meaning is non-domain bifurcation PCI itself is very small myocardium dealing with a small myocardium. And so totally different after the, anyway, before that any ischemia study is more clear that one. And so think about the cloud bifurcation, lots of cloud in the worldwide. We think about optional T-stent. However, total clinical outcome actually totally different, just depending on myocardium size. Personally, I think it's right.
Okay, so Dr. Bakr, one question. So for that concept, so is there any room for physiologic assessment for the non-left main bifurcation lesion?
All right, so we have lots of insight from the previous study. Even any big vessels, 90% compromised, more than 70% of negative FFR. However, we don't have any ideas before that. 90% stenosis after main stent, do wiring, kissing balloon inflation. And I've shown that some data, paradoxically, aggressive treatment makes more adverse outcomes. We have data on that. And so, however, still, we don't too much, struggling with it. How to, just review alone. That is my message. All right, thank you.
Just one comment here. I also have this comment of drug-eluting balloon in side branch. I think it's a very popular strategy. People think that it will help to maintain the patency in the longer term. But the truth is that, again, there's never a data to support the use of drug-eluting balloon versus a conventional good old balloon angioplasty in the side branch bifurcation lesion. In fact, the only trial that I know of called the debut trial was a negative trial comparing DEB versus POVA versus DES. So I think the concept of DEB in side branch PCI is still something that needs to be further evaluated. Just bear in mind that DEB is only a drug delivery carrier for reduction of intimal hyperplasia. It does nothing to the vascular recoil, which is the most important mechanism, I think, of a side branch osteostenosis.
Okay, so thank you for all speakers and panelists. It's time to close this session. Thank you.